Hello, distinguished guests and ladies and gentlemen. A very good morning to all of you. And let me welcome you to the Pediatric Rheumatology course for rheumatologists, pediatricians, and trainees for the year 2024. To start off the proceedings with an auspicious start, it is my great pleasure to invite the following distinguished guests for the lighting of the traditional oil lamp. Dr. Paediatric Rheumatology, President of the College of Specialists in Rheumatology and Rehabilitation and Consultant in Rheumatology and Rehabilitation. Dr. Duminda Samarasinghe, President of the Sri Lanka College of Pediatricians and Consultant Pediatric Cardiologist. Associate Professor Elizabeth Ang, Senior Consultant in Paediatric Rheumatology in National University Hospital, Singapore, who is also Adjunct Associate Professor at Department of Pediatrics at National University, Singapore. Professor Suma Balan, Professor in Paediatric Rheumatology, Department of Rheumatology and Clinical Immunology, Amrita Institute of Health Sciences, Kochi, India. Professor Suleiman Mohammad Al-Mayyouf, Professor of Pediatrics, Department of Pediatrics, College of Medicine, Al Faisal University, and Senior Consultant at King Faisal Specialist Hospital and Research Center. Dr. Jayatri Jagoda, Consultant in Rheumatology and Rehabilitation and convener for today's event in Pediatric Rheumatology. Dr. Dilruksh Tennekon, Consultant in Rheumatology and Rehabilitation and Treasurer of the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka. And finally, Dr. Himantha Athakorala, Consultant in Rheumatology and Rehabilitation and convener of the APLA Young Rheumatologists. If you could proceed for the lighting of the oil lamp. To start off the proceedings, may I request on stage the following dignitaries: Dr. Paediatric Rheumatology, Dr. Duminda Samarasinghe, Associate Professor Elizabeth Ang, Professor Suma Balan, Professor Suleiman Al-Mayyouf, and Dr. Jayatri Jagoda, please. Thank you. So, to start off the proceedings for today, first of all, the President's speech by the President of the College of Specialists in Rheumatology and Rehabilitation and Consultant in Rheumatology and Rehabilitation. I cordially invite Dr. Paediatric Rheumatology.
A very good morning, everyone. It's with great pleasure that I welcome you all to the Pediatric Rheumatology session for rheumatologists, pediatricians, and trainees. This session is being conducted by the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka, in collaboration with Sri Lankan College of Pediatricians with esteemed patronage of APLA. We are immensely grateful for their support and dedication in making this event possible. This event marks a significant milestone in Sri Lanka's first ever International Pediatric Rheumatology course, and we are truly honored to have you here with us today. And I would like to extend my special welcome to our esteemed faculty, including Professor Suma Balan, and Prof. Sumaira Farman, connected online, and Prof. Sulaiman Mairuf, and the Professor Elizabeth Ang. We deeply appreciate your commitment and willingness to join us despite of your busy schedules. To our participants, I encourage you to engage actively in these sessions. And I hope you find this program both informative and inspiring. So thank you very much.
Next, to address you all, it is my great pleasure to invite the President of the Sri Lanka College of Pediatricians, Consultant Pediatric Cardiologist, Dr. Dubinda Samarasinghe.
Thank you. Very good morning to all of you. Good morning, ladies and gentlemen. So, first of all, I should thank the international faculty for coming all the way from the region to participate in this very important workshop. I should also thank College of Rheumatology, especially Gayatri, who has been involved for last 2 or 3 months in organizing and calling everybody and arranging all the infrastructure facilities. It's not an easy task to organize a workshop like this, but she carried out everything, and with the support of Dr. Dubinda Munidasa. I should thank the College of Rheumatology and Rehabilitation for doing everything and for organizing this workshop. Our theme during this year, our main target is to fill knowledge gaps and to correct wrong practices among our day-to-day practice. And I hope this workshop will help for you to improve your knowledge on rheumatology and rehabilitation, and especially in relation to childhood rheumatology diseases, and hope it will help all of us to improve the services that we provide to children of Sri Lanka. Thank you.
Thank you, sir. Next, to speak a few words, I cordially invite representative of APLA Special Interest Group in Paediatric Rheumatology, Associate Professor Elizabeth Yang.
Hi, good morning. Dear Presidents of the College of Sri Lankan Rheumatologists and the College of Pediatricians, I want to thank you for inviting us to come and be part of this Peds Room course. I stand here also on behalf of APLAR, that's the Asia Pacific League of Associations for Rheumatology, and as the co-convener of the Pediatric Special Interest Group. One of the major aims of APLAR is the training and education of Peds Room providers in the region, the Asia Pacific. Because we recognize that most of the published knowledge and guidelines on Peds Room come from Europe or North America. Yet there are unique characteristics of patients and healthcare systems in Asia that make care for these children quite different and honestly quite difficult. Peds Room subspecialty training in Asia is also very variable and diverse and sometimes non-existent. Nonetheless, we in Asia are united in desiring to bring the best care possible to children with rheumatic diseases. The 4 speakers from Asia Pacific today are uniquely placed to share not just knowledge, but also experience within our context that we hope will have special bearing for you in Sri Lanka. To our best ability, we will share with you evidence-based knowledge and how we apply this in our specific situations. But we also hope to teach you aspirationally. So we hope you'll enjoy the next 1.5 days. Thank you very much.
Thank you so much, Prof. Ang. Now, to deliver the vote of thanks of the inauguration, I cordially invite Dr. Jayatri Jagoda, Consultant in Rheumatology and Rehabilitation at LRH, as well as the convener for today's program. Over to you, Madam.
Thank you, Matthew. It's with great pleasure and relief I'm standing here today at this moment because this last year when we met in APLA, Sumaira, who is not here, Sumaira Farman, who is the convener of Pediatric Special Interest Group, and Dr. Elizabeth Ang, who is here, they wanted me to take this up, this challenging task. Then from then onwards, there has been a lot of, communication going on. And I'm happy to say with many people's support, we are able to make this a real success. So first of all, my gratitude should go to APLA for giving us this opportunity to learn from the regional experts, and my personal thanks go to Dr. Sumaira Farman, who is the convener of SIG, and Dr. Elizabeth Ang, who was, coordinating the team very much all the time, pushing the APLA secretariat to do things, and sometimes assisting Sumaira, and Dr. Suma Balan from India. She was always agreeing to everything, the timing and everything. She was telling yes, and Professor Sulaiman has been always very friendly, and it was very easy working with you all. Thank you so much. Please accept my heartfelt gratitude. So, and then I would keep my college aside. Dr. Duminda Samarasinghe, who is the president of Pediatric College, we were, having many communications in between, and he was very supportive as well at all stages. And from that end, I must thank Dr. Anuradha also, who is here, doing a lot of coordination between the two colleges to get little things done, and the help in the front desk. I'm really grateful. And from our college, Dr. Partha Dissanayake, who is the president, who was always very positive and supportive, and it was very easy to do everything with him. And I must say, the wind behind all this, the sailing of CSR-RSL is Dr. Duminda Munidasa, who is there for all the support, advice, and letting me go through all the hiccups smoothly. And my gratitude to you, sir. And Himantha, Dr. Himantha Attukorala, you all know him. He's a celebrity in APLA also. He's known to APLA. So Himantha did a lot of work in, the registration work and all the online things he handled. Thank you, Himantha. If not for you, my expertise in that field is nil. So thank you so much. That was a great help. And I must not forget my juniors, Bhatia and Diniti and Dinusha out there. They were a big comfort all these days. And last but not the least, all the participants from both colleges. I know it's a rainy day. They are finding it difficult to come. I hope that they will come in more in numbers. And if not for your participation, this won't have a meaning. Make this an interactive session so that you can take it home. And our sponsors, there were mainly a few sponsors actually, Roche, and then Sidus Cadler Sunshine, and George Stewart Specialty Care, George Stewart Lectonova. Those were the few sponsors that we had. Without them, this wouldn't have been possible. So I'm so grateful for everybody for making this event a success. Thank you so much. Hope you will gain from this. We will, much ado, we'll start the academic program from here. So you can take the seats there. I myself will chair the first session. first session is a kind of an introduction to juvenile idiopathic arthritis or inflammatory arthritis as such, and the pitfalls, numerous pitfalls that we can fall in diagnosing early arthritis. In that sense, we have two speakers and two, Dr. Sumaira is joining online. She has sent us a recording, but she's joining online for the interactive session. And then Dr. Elizabeth Ang, who is there with me from yesterday. She's she's a senior consultant in pediatric rheumatology in National University Hospital, Singapore, and also adjunct associate professor in the Department of Pediatrics in the National Centre, Singapore. So they both will share the session, and Liz will contribute to the discussion as well.
Hi, everyone. While we're waiting to set up, just want to say hi again. Yes, my name is Elizabeth Ang, but please call me Liz or Elizabeth. We do hope that this will be as interactive or as informal as possible. And just to help us as speakers, I would love to know the audience a little bit more. So by a show of hands, how many here are pediatricians? Okay. All right, how many are adult rheumatology trainees or trained in adult rheumatology? That's most of you, huh? How about those of you who are being trained in peds rehab or finished training in peds rehab? Not so many. How about adult rehab training or finished adult rehab training? Okay, so did I miss any group out? Pediatric trainees. Okay, so mostly adult rheumatologists and pediatricians. Great. Because that is kind of the focus of our first talk. And let me turn this on. Yeah. Arthritis in children and adolescents, an overview for the general pediatrician and adult rheumatologist. This will be the outline of the next 45 to 50 minutes together. And in blue boxes or in blue words would be how I highlight where children may be different from adults. This man is Sir William Osler, and it always makes me feel better when he himself, the great clinician, said, "When a patient with arthritis comes in the front door, I try to go out the back door." And I think that really reflects that joint pain or joint problems is a very under-recognized, under-taught condition in med school.
Recording
and
in
I'm
progress.
guessing that for the adult providers here, you are thinking when a pediatric patient comes in the front door, I try to go out the back door as well, because children can be quite scary to those of us who are not familiar with them. Now, I spent about a day or half a day with Dr. Jayatri and many of you yesterday, and I get a feeling that you're actually really highly trained and competent. So for the next few slides, I'm really going to rush through it and get more into the meat and the practicalities of peds rheumatology. Generally, the approach to joint or limb pain in a child is quite simple in the sense that you first ask yourself, is this child sick or well? And in pediatrics, when we say a sick child, we usually mean the child is either having a very high fever, a prolonged fever, more than 7 to 10 days, or in severe pain. That would be our first question that we want answered. The second question we want answered would then be, is this child with pain having a problem predominantly in the joint or in the limb? And the third approach to that would be, is only one joint involved or many joints involved? So in approaching a child with joint or limb pain, it's these three questions: well or sick? Number two, joint or outside of joint? And number three, one joint or more than one joint. The focus for a pediatric rheumatologist, at least as an outpatient, would be in a fairly well child who has predominantly joint involvement. And you can see on the left-hand side that the differentials for one joint or more than one joint are many. And it does help to be able to differentiate if this is monoarticular involvement or more than that. Let's start with a case. This is a 3-year-old girl with a swollen right knee and limp. And in pediatrics, if you ask for a history of trauma at this age, you're probably going to get some sort of history that the child fell down, because at 2 or 3, they're just learning the motor milestones of running and jumping and skipping. So that trauma history may not always be relevant. When you ask them, they think maybe she began limping before the fall, but they're not sure, and her gait is quite unsteady. She herself doesn't complain of pain, but she seems worse in the morning. And when you examine her, you can see that there is a little bit of a flexion contracture in the knee, and on palpation, it's warm, there's an effusion, there's slight tenderness, limited flexion. So this is a well child with predominantly joint involvement, not the limb. And now we need to ask ourselves, is it only one joint or many joints involved? How do we do that? Well, she's not complaining of anything else, so we really have to use the physical exam as quickly as possible to decide if this is one or more than one joint involvement. And that's where the PGALS comes in, the Pediatric Gait, Arms, Legs, and Spine exam. I always remind the younger doctors that this is not a joint-specific exam in the sense that if a child comes with right wrist pain, you don't do a PGALS, you examine the wrist. But if you want to quickly screen the other joints in under 5 minutes, then you do the PGALS exam, which is a screening exam. I'm happy to provide you with the notes from my slide, which will also include this link where I created a video to demonstrate the PGALS in a cooperative 5-year-old child. But because I think that you are all way past this, I'm going to skim through the PGALS and go straight to what about kids, right? Sometimes a 2 or 3-year-old is not going to cooperate with all these maneuvers. So what do? Observe. Let them move or let them play. And for this, I'm going to show you a video of how a joint exam in a child must be rather opportunistic.
Have a look at this short video. It's a young girl aged 22 months old who brought to attention of healthcare professionals that she observed her parents limping. She'd been quite well by herself. She'd been limping on and off for the last few weeks. Have a look around the room. Look at her face, check on further clues. Do you think she needs discomfort or not? And what do you think about her gait? What's your gait now? What do you observe? Is this normal gait for a 22-year-old, do you think? Clearly she's limping, and she has what we call an antalgic gait. She appears to be in discomfort. You can see here that she's quite reluctant to have her wrist passively moved. If you look carefully, you see that she is drawing her arm. She appears to be in discomfort. She doesn't say anything about her, so do you think she's in pain or not? She's too young to tell that she's in discomfort, so you need to be very careful around those signs of her being in pain. Comparing the left side, she moves her left wrist remarkably well. Here she is walking alone, clearly she's walking limping, an asymmetrical gait. She's walking with her hips and her knees flexed. Look carefully. You can also see the knees appear to be swollen. Here she is standing, and you see the knees quite clearly flexed. Around the back, we have a good look at her ankles also. If you look carefully, you'll be able to see swelling in the back of the legs around her ankles. You're not able to see the tenderness very clearly, but you feel the indication which has got some strong artery and ankles. As illustrated here. She also appears to have calf voice on the left, which may indicate chronicity or joint involvement. Here we are standing, you see the legs are flexed, the knees do appear swollen, particularly on the right hand side, and the ceiling pointed out to us that the swelling is just above the knee.
All right, I hope you had fun looking at that video, which demonstrates a child who is not complaining of any pain at all, still doing all the things that you expect a 2-year-old child to do, but actually has many joints involved in arthritis. This video is from this website called PMM, Paediatric Musculoskeletal Matters, courtesy of Dr. Helen Foster, who is a big friend of APLAR, and there are many resources, educational resources that are free of charge. But let's come back to our girl, this 3-year-old girl, right? Let's say you know that her right knee is involved, but the rest of the joint exam is normal because you've done a good P-GALS. So what next? Well, most of the time you'll do some tests. You may do a knee x-ray, and the radiologist reports knee joint effusion, no fracture. You might do a full blood count, which looks quite unremarkable. The ESR is 24, not that high. In children, it's easy, if you want to remember a ballpark figure, anything less than 20 is probably okay. CRP in this 3-year-old is normal, and she has a negative rheumatoid factor and anti-nuclear antibody. So what's her diagnosis? Well, this girl, to us as pediatric rheumatologists, has very clearly a chronic arthritis, and really demonstrates that kids, even a 22-month-old kid, can get arthritis too. She has JIA, which by definition is arthritis of unknown etiology, occurring before the 16th birthday, with symptoms persistent for at least 6 weeks. In a child, when the history is not so clear, then you rely on the physical exam to look for signs of chronicity to decide that it's probably been going on for more than 6 weeks. Depending on the study you read, you will get different incidences, so I won't go into really how many children it affects, but for you who have seen these patients, you know that JIA is the most common pediatric rheumatology condition. JIA in kids, like in adults, can affect any joint, and in peds, we subdivide them into 7 subtypes, according to the International League of Associations for Rheumatology, that's ILAR. And they are as follows: oligoarticular, polyarticular, and we divide that to RF negative and RF positive, enthesitis-related arthritis, psoriatic arthritis, undifferentiated arthritis, and number 7, systemic arthritis. I put systemic arthritis quite different because I believe that it is really very different, not just in presentation, but also pathophysiology. How does the subgroup of JIA compare to adults? I've shown that here on this table with adult type arthritis on the left and pediatric on the right. I would say that within the 7 subtypes of pediatric arthritis, the one that resembles rheumatoid arthritis the most is just the polyarticular RF positive, and everything else is a little bit special. I suspect most of you here know about the 7 subtypes, and I'll go through them really briefly. It's not so difficult to remember. Oligoarthritis means that 4 joints or less are involved in the first 6 months of the disease. Beyond 6 months, if more joints get involved, then they're called extended oligoarthritis. And for these ILA classifications, there are many exclusions, which I'm happy to leave here in the notes. I've also left a little bit more notes more on the oligoarthritis. Generally, females are affected more. There is usually 2 peaks, one in early childhood and later. And in the West, this is a type associated with uveitis, although I don't think that that association is as strong in Asia. For the polyarthritis, then it means joint involvement is 5 joints or more. sinusitis-related arthritis is something that I think we must take note of because there seems to be a higher proportion of ERA in Asia than in the West. By definition, it's a child with arthritis and enthesitis, or if they don't have both, then at least two of the following: either a history of SI joint tenderness or inflammatory lower back pain, positive HLA-B27. If it is a boy who is more than 6 with lower limb involvement, think about ERA, or if there's acute symptomatic anterior uveitis, or a positive family history of the following. Psoriatic arthritis, I think, is less common in Asia compared to the West, and it's not so hard to remember. It's really a child with psoriasis and arthritis, or the other symptoms of psoriasis, namely dactylitis, nail pitting or onycholysis, or psoriasis in a first-degree relative. I'm curious about how common psoriasis is in Sri Lanka. Does anybody want to share, or would you say very common? Very rare? Somewhere in between? Yes. Okay, thank you for sharing. In adults, but in peds, at least for me, I think I can count the number of psoriatic arthritis patients I have with just one hand.
I just had seen 2 patients all this time. It's very rare. I haven't seen
very
many.
rare.
Yeah.
In pediatrics. Thank you. Thanks for sharing that. And finally, systemic arthritis is arthritis in one or more joints with fever or preceded by fever. But remember, this fever must be daily. That means up and down for at least 3 days. The old, or this criteria, requires that the fever lasts for at least 2 weeks, but with increasing awareness of SJIA, some can make the diagnosis a little bit earlier. The clue is the presence of a rash that is evanescent, meaning it comes and goes, and if the rash is fixed, then it might not be SJIA. There also is generalized lymphadenopathy, hepato and or splenomegaly, and serositis. Very often this presents as chest pain or abdominal pain. SJIA is interesting in that it has a complication known as MAS, macrophage activation syndrome, that may be present in anything from 10 to 40% of children with SJIA. Here I leave for the notes all the exclusion criteria. So now we know that there are 7 subtypes. What's it like in Asia? I quote a study that was done in Southeast Asia, which showed that in Malaysia and Thailand, the most common subgroup was systemic JIA, whereas in the Philippines, the most common subgroup was polyarticular RF negative JIA, and in Singapore, we had about 1/3 of our patients belonging to the ERA subtype. I wonder what it's like for you all here in Sri Lanka. What's your feeling about it?
We don't have our own figures. I can give you only a rough idea. We see quite a number of polyarticular JIAs, systemic onset JIAs, and EIAs, enthesitis related as well. But as I said, psoriatic arthritis is very rare. I haven't seen many. And there are kind of like undifferentiated ones as well. Yeah. I'm not able to give you exact figures.
That's okay.
Yeah.
That's okay. Thank you so much. Your experience is really important. And again, some of you may be wondering, why do we need to care, right? As in rheumatology, sometimes even without a name, we treat what is before us. But as we get better in our practice, the ability to subtype them also gives us the confidence to know how to counsel in terms of outcome and to decide on reducing medicine if there is remission. In any case, just as Dr. Jayatri, Madam, shared, enthesitis-related arthritis is not uncommon in Sri Lanka, and that is something that needs to be recognized. The interesting thing about kids with enthesitis is they may not have joint pain as much as pain at the insertion of the tendons that can cause things like heel pain or swelling around the Achilles. Now, This one is particularly small on purpose. It's just to highlight that in the last 5 years, people have tried to regroup the classification of JIA because they feel that perhaps these 7 subtypes of JIA, according to ILA, are not as practical, and it would be more practical to group them according to the phenotype into 5 groups as is follows, and this was proposed by Printo. As you can see, many things have happened over the years. This chart just shows how the thinking of JIA has evolved over the years, and we have records of the first classification or definition system from 1959 to the latest one in 2019. For practical reasons, I think it is good to know the ILAR classification, as most of the studies would be done according to that. But if you read some studies that go according to the provisional Printo classification, I hope you understand that that was in order to phenotype them a little bit more broadly to further encourage studies according to the phenotype. I'm sure as we get better in medicine, we might even have genotype-phenotype correlations, but we're a long way from that. This slide I will leave for your reference, highlighting the differences between the ILAR 7 subtypes and the Printo 5 subtypes. I think the best thing that I tell myself is to hold on to these classification criteria lightly. After all, they are used for classification more than diagnosis. I will skip this in order for us to go into some practical aspects. Let me share some common misconceptions in childhood arthritis. The first is that the child is too young to have arthritis, it's just growing pains. I think from today's video and case presentation, and maybe from your own experience, you know that arthritis can start in infancy, and the oligoarthritis subtype has actually a peak incidence at the toddler age group. Remember also that arthritis may be part of a more systemic problem than JIA, for example, the genetic autoinflammatory diseases that Professor Suleiman will talk about later, and these patients may present very young. Misconception number 2 for children: there's no pain, it cannot be arthritis. Again, I hope today's video has showed you that children don't often complain of pain, especially the neuroatypical children, like the kid with autism, or maybe the non-verbal kid with trisomy 21. I think that's why a lot of us pediatricians love being pediatricians. The kid has to be really uncomfortable to start making you notice, quite different from adults. Or this misconception might seem true because children compensate very well, meaning they are in pain, but they live through it and they make do with their lives through it. Let me show you an example that I treated more than 10 years ago. At that time she was 5 and she had a history of slow gross motor development. In fact, her mother tells me, I thought she was just very lazy. Every time we went out, even at 4 years old, she wanted to be on a stroller, whereas her younger sister would be fine walking around. The mother also said, at 2 years old, I brought her to see the orthopedic surgeon who noticed fixed flexion deformities, and their presumptive diagnosis was arthrogryposis, and they sent her for physiotherapy. But she brought this 5-year-old girl again to the doctor, the primary care, what we call GP, because mom noticed that she had difficulty straightening her elbows and fingers. She's never complained of pain. She was seen, and the referral letter to me wrote, examination of joints normal. So why did she come to me? Well, the GP or the primary care doctor did an x-ray of the hands just in case, and it was reported as periarticular osteopenia. So even though the exam was normal, the GP thought I better refer to a pediatric rheumatologist. And she was referred to me. These were her hands. To an adult doctor, it might look quite normal. Kids are sometimes a little bit more chubby or pudgy. But when I asked her to move her hands to the extremes of motion, there was definite limitation. Here's a video of her running with her sister. She's the older one. with her hair let down. Her healthy sister is the one in the ponytails. This is her with a little bit of treatment, and I hope you can see that her gait, though she's able to run, is not quite as smooth as her sister. She is not bending her elbows or bending her knees as much as her sister, and I'll show that to you again. Perhaps this is not such a big problem in Sri Lanka when kids may come quite late, and so the signs are more obvious, but definitely we are trying to make sure we pick these kids up as early as possible. She turned out to be a polyarticular JIA, and she was treated, and now she's off medicines and doing very well. So, why do we have this misconception of number 2? I think it is for the first 2 reasons I mentioned, but also because we must get better at joint examination in children. We think they're not in pain because we may not be stressing them in the exam to the extremes of motion, but in fact, if we did, the pain would become very obvious. How about misconception number 3? Blood tests and x-rays are normal, it cannot be arthritis. Well, that's not true because as adult rheumatologists, you know that arthritis is diagnosed on history and physical exam, with the exception of deep joints like the hip and sacroiliac joint, where an ultrasound or MRI is helpful. And I was happy to learn from Madam that it is possible to get MRIs here of joints that are difficult to examine just by looking and feeling. Remember that the investigations in JIA may be normal. The raised inflammatory markers are often only seen in poly-JIA, systemic JIA, and ERA. Ferritin can be high in systemic JIA. Autoantibodies do not make the diagnosis but help in classifying and prognostication. And as I said in the previous slide, imaging may be necessary for deep joints. Misconception number 5. Arthritis is just about the joints. No. Sometimes arthritis can present with enthesitis that looks like cellulitis. I remember seeing a girl who was admitted multiple times for 4-foot cellulitis because it got swollen, it got red, and every time she got antibiotics, she got better. But she turned out to have a arthritis that was really midfoot tarsitis, or midfoot arthritis or tarsitis. Sometimes the arthritis can result in dactylitis, and of course, JIA can be associated with uveitis, meaning that the inflammation extends beyond the joints. Okay, let's say we've made the diagnosis of JIA. What are the complications we should be looking for, sometimes at diagnosis and even as you go along? Of course, with long-term joint inflammation, abnormalities of growth, which may be local or systemic, uveitis, bone health, and psychological effects, which we don't often think about. Oops, sorry. Now, how does arthritis affect growth in children? It really depends on the joint involved. For example, if there is uncontrolled arthritis in that knee, that leg somehow tends to be longer, whereas if there is uncontrolled arthritis in the TMJ, the affected jaw tends to be smaller, and that is because the growth plates and how bones grow are region-specific. I remember speaking to a rheumatologist from Malaysia, and I asked her, how does she screen for TMJ? She said, Liz, our kids are so bad, the TMJ is the last thing we look at because they're so bad in all their other joints as well. That may also be the case in some of the clinics that you practice in, and I think fair enough, if the other joints are active, that will probably determine your treatment decisions anyway. But if you are concerned about TMJ, one way of screening is just to look. The chin will move to the affected side of the TM joint. And another good screen is to ask the patient to put 3 fingers in between their teeth. It should be their fingers, not your fingers, okay? Uveitis. I showed 2 pictures here because uveitis can affect JIA in 2 ways. This very red eye is very obvious, and that's called acute symptomatic uveitis, which affects mainly the ERA subtype. But what we're worried about is the asymptomatic uveitis, causing no redness, sometimes no visual disturbance, but still significant inflammation. This tends to happen in the non-ERA subtypes. The general guidelines are to refer early to the ophthalmologist for screening, usually within 6 weeks. Sometimes when you're not sure if a child has arthritis, a positive finding of uveitis can make the diagnosis. Generally, the studies that have been produced in Asia show that uveitis incidence is much lower here than in the West. And I think Madam was sharing with me that that's also her experience, even if she doesn't have the numbers, but the experience is the same. This then impacts the frequency of screening. If we follow the British guidelines for screening, some of these kids will need 3 monthly screenings for 6 to 8 years. But if that incidence is lower in Asia, we may not need to follow those guidelines at all. One thing that is helpful is patient education on symptoms and seeking immediate attention. The British guidelines, I know, even say that once a year the parent should just cover one eye and make sure the kid can see. I suppose that's one way of doing it if resources are limited. Again, treatment is really important because structural damage can occur, and once structural damage occurs, it's irreversible. When I refer to structural damage, I'm talking about band keratopathy, cataracts. So in summary, when thinking about treatment, early and right diagnosis matters because JIA is more common than you think. Late diagnosis can cause permanent damage in the joints and the eyes. And I suppose in the case of SJIA and MAS, late diagnosis can cause death. Right diagnosis and treatment can allow children to live really well. So let's go into how we actually treat these kids. I'm sure you in adult rheumatology know these big arms of treatment for JIA in adults, and it's quite the same in children. It's steroids, non-steroids, conventional synthetic DMARDs like methotrexate, leflunomide, biologic DMARDs, and then the newer ones in the last 10 years have been the targeted synthetic DMARDs, namely the JAK inhibitors. There are many, many guidelines, and again, they come from America, from Europe. Some of the countries in Asia have their local guidelines. I found one from India from 2022, written by all the esteemed pediatric rheumatologists there. And most recently, the EULAR, which is the European guidelines, have come up with recommendations for systemic JIA that cut across adults and pediatric Still's disease. Watch this space. APLAR is going to come up with guidelines, and we hope to publish them in 2025. I'd like to quote Prof. Tash, another pediatric rheumatologist in Singapore, who recently said, "We are subspecialists. We don't always follow the guidelines. We write the guidelines." Thankfully, not all pediatric rheumatologists have so much chutzpah or confidence, but it's something to think about, meaning hold on to guidelines lightly because they really need to be contextualized to your practice. Having said that, I will very quickly share with you what these guidelines share, and then my personal opinion on that. For oligo JIA, first step, if it's a few joints, inject it. If that doesn't work, or the patient develops more joint involvement, then add a DMARD, MTX over leflunomide, sulfasalazine, or hydroxychloroquine. Not that different from adults, right? MTX first line if the injections don't work. For polyarticular JIA, same, methotrexate first, and failing which, we're going to DMARDs, which is what is included in the table here, which I took from the 2019 or 2020 ACR guidelines. And I share them with you because I think they are practical and they are a way that we should in some ways be aiming towards. If TNF doesn't work, abatacept or tocilizumab, and I'm glad in Sri Lanka you have tocilizumab, even if the supply is erratic. Adjunctive therapy does include NSAIDs and steroids, and of course non-pharmacologic PT and OT, which many of you are well versed in, having been trained also in adult and pediatric rehab. What about systemic JIA? Again, this is just for your reference. This was from the ACR guidelines from a few years ago, but have been superseded by the EULAR ones for adults and pediatrics. And this is what I'm quoting or showing right here. I leave this really just for reference, and I'm happy to share these slides with you. But let's go into a little bit more practical things, okay? What's another misconception in JIA? Well, a short course of oral steroids should be fine. Then let's see. The problem is, steroids can be harmful if the cause of the bone and joint pain is infection or malignancy. Because let's be honest, sometimes it's not that obvious that it's JIA. And if you're using response to steroids as a diagnostic or as a way to diagnosis, it's not a good idea. So to this, I would say maybe to adult rheumatologists, don't use steroids when in doubt about diagnosis, and definitely don't use steroids long term. So then what do we do about steroids in JIA? There are 4 indications for steroids in JIA. Number 1, as a bridging medication, because conventional DMARDs like methotrexate take at least 6 to 8 weeks to work. The biologics and the JAK inhibitors are faster, but not always available. So the truth is, most of the time we'll be using MTX. In patients who are in pain and you cannot wait for 6 to 8 weeks for the MTX to work, go ahead and use some prednisolone at these doses, but taper them quickly as the child gets better. A second indication for steroids in JIA are for severe symptoms or flares. In these patients, you can pulse them, anything from 10 to 30 milligrams per kilo per day, but this is short term. The good thing about pulses is that they work really well and really quickly, but they don't have the metabolic side effects of chronic steroids. Sometimes chronic low-dose steroids may be needed, and if you find that that is the case in your patient, try and aim for a dose of less than 5 milligrams, or for a child less than 0.15 milligrams per kilo, whatever is lower. I suspect some of us think differently about that, and if you have cases that we can discuss, I'm happy to, let all of us speak into the use of steroids for JIA. And of course, the 4th indication for steroids is if the patient has macrophage activation syndrome in systemic JIA. Intra-articular steroids are really, really helpful. I love using this when it is indicated, usually for patients with very few and injectable joints. It can reduce the risk of limb length discrepancy, especially in chronic knee arthritis. The duration of action is anything from 3 months to a year, but the problem is in young children, they may need sedation for it. People have talked a lot about what's the maximum we can inject a child's the same joint, and there's no head-to-head study for this. For me, I think up to 3 times a year would be acceptable. I wonder what Dr. Suma Bala and Prof. Suleiman think. Would you do 3 also? Okay, few. Yeah. The important thing, when you quote that it can work for 3 months or a year, is to make sure that you use the right formulation. And in guidelines, it will be triamcinolone hexacetonide. That's not to say that if you have another steroid, you don't use it. It's just that if you use something else, it's probably not going to work for as long or as sustained as triamcinolone hexacetonide. And that boils down to the fact that triamcinolone hexacetonide size allows it to stay in the joint for longer, and also makes sure that there's less systemic side effects. Let's talk a little bit about methotrexate in JIA. In kids, I know that the textbooks will say 10 to 15 milligrams per meter square. That about works out to 1 milligram per kilo, and I find that easier to remember and also just more practical. I don't have to calculate their body surface area. Generally, sub-Q bioavailability is a bit better than oral, but I think sub-Q is not always available, and so I want to comfort you that even though you don't have sub-Q, it's just a little bit better than the oral. There are studies that show that splitting the dose is better for bioavailability. So if a child is taking 8 tablets, that's 20 milligrams, it might be better for them to take 4 in the morning, 4 at night, or 4 on Saturday, 4 on Sunday. But if you think that splitting the dose is going to affect adherence and compliance, go ahead and ask them to take it at one time. This is the art of medicine. Food does not affect bioavailability, so they can eat it before, after food, it doesn't matter. Side effects. Oral ulcers I find are rare because the mechanism of action in JIA is not the same as in cancer. Nausea can be significant, and though it is not organ threatening, it can be very limiting. And in some of my patients, I've had to stop MTX because of that. Abdominal discomfort and transaminitis may be present, but usually doesn't last for, the abdominal discomfort doesn't last for more than 1 to 2 days. In terms of monitoring, I usually monitor the FBC, creatinine, and just the ALT, or what you know as the SGPT, 1 month after initiation or after every increase, or and then after that every 3 to 4 months. You must give folic acid. In Singapore, we give 5 milligrams every week, the day after MTX. If what you have is 1 milligram, they can take that 5 days a week, 6 days a week. Remember that it takes 6 to 8 weeks to work. A special note to the adult rheumatologists, don't be afraid of MTX. I know from my adult friends that they usually give adult patients 7.5, at most 10, at most 15 milligrams of MTX a week. So when they see me using 20 and 25 milligrams, they get very scared. Trust me, children tolerate it better than adults. They have much fewer comorbidities in their liver, and so they do very well. Even if they have an elevated ALT and AST, what you do is just stop the MTX for about 2 to 3 weeks, recheck it. If the ALT and AST go back to normal, and it often does, you can restart MTX at the dose that the child was on. In children, the ALT and AST often go up because of a viral infection, and so you can be quite confident that it will come back down when you stop MTX. Okay, what about the other conventional DMARDs? I leave some notes here on sulfasalazine and leflunomide. I think I get a sense that leflunomide is readily available here. And there are studies, and I think my personal experience is that it can work, sometimes in combination with MTX as well. Sulfasalazine is also very useful and generally safe. The main thing to warn patients about are allergies, which can happen weeks after, namely Stevens-Johnson, toxic epidermal necrolysis, or DRESS syndrome. So when starting sulfasalazine, it's important to warn them about these allergies and to tell them to stop the medication immediately if the allergy or the rash develops. Biologic DMARDs, of course, the most common ones are anti-TNF. I think I learned from Madam that infliximab is available in Sri Lanka, but unfortunately not always, intermittently. And of course there are others, and I get the sense that here you have tocilizumab, but no anakinra. I think it's beyond the scope of this talk to say which you use when, so thankfully I will not be going into that. Just some practical problems regarding biologics. There is the possibility of reactivation of latent TB and hepatitis B infection, so patients who are going to be started on biologics need to be screened for it. If they have evidence of latent TB, usually just treat for 4 weeks of anti-TB meds, then start the biologic and continue the anti-TB treatment. There is the risk of serious infections, maybe demyelinating CNS disease, but no proven risk of associated cancer. While on biologics, patients should avoid live vaccines. For the pediatrician, that would be oral polio and maybe MMR, although there is increasing evidence that in certain circumstances, given MMR may be allowed. So really, which biologic do you use? There are so many, and one way of thinking about it is on the left-hand side, looking at which cytokine or which cell or which pathway is being blocked. And then on the horizontal axis, looking at the condition that you're actually treating. The green boxes mark what follows given knowledge. Red boxes generally is saying this combination is not going to work, and yellow is kind of a maybe, okay? Right now I'm going to share with you, in some ways, my personal opinion or practical pearls. I've mentioned hold on to guidelines lightly. The old guidelines said that in oligo-JIA, NSAIDs are first line, and I think that's fair. But I think it's important to know that NSAIDs are temporizing, and I don't think it's going to be treatment itself, meaning they're going to need something more chronic like injections or maybe DMARDs. For poly-JIA, you start MTX early and, if possible, biologics soon. Biologics up front would be ideal for kids with SI joint involvement, C-spine, hips, or TMJ, or if at presentation they have bad uveitis and structural damage. The ACR, the American guidelines, say that the ankle, wrist, and hip joint are high-risk joints, and they would start biologics, or they would consider biologics early up front for them. I think SI joint and C-spine are, to me, more high-risk joints. The advantage, I have the most experience with adalimumab because in the last 5 years, 40 milligrams has cost us about $50 US, which is still a lot, but it's less than 10% of what it cost when I first started using it maybe 10 to 15 years ago. And that has made adalimumab so easy to use. Here you have infliximab, and you have an advantage in that infliximab allows for dose adjustment. In rheumatology, we'll use up to 10 milligrams per kilo every 2 to 4 weeks for a bad inflammatory condition. Here are just some practical pearls for kids who fail TNF. I get the sense that TNF is not so available here, so maybe it doesn't make so much sense for me to talk about it. Maybe I'll just highlight what we mean by secondary or primary failure. Secondary failure means that the TNF inhibitor works for a while, and then suddenly seems to stop working. The patient will usually say, I feel better for about 1 week, but for the next week, until I'm waiting for the next dose of adalimumab, I start to get pain again. This often is because of the formation of anti-drug antibodies. But like I said, maybe I won't talk too much about this because TNF is not used so much here.
Liz, the TNFs that we have is infliximab and adalimumab. It will be useful to share your experience.
Okay.
Yeah.
Sure. Okay.
Because it's erratic supply, but they're around.
Okay. So in the case of secondary failure, what I do is I really just increase the frequency. So adalimumab every 2 weeks, I start using it every week, or increase the dose in the case of IV infliximab. I can check for anti-drug antibodies. Somehow the drug companies are offering that for free in Singapore, but if you cannot, it's fine. You can presume that this is what is happening. Of course, add MTX. Some of the guidelines say that if you're going to start biologics, just give it together with MTX. And that's probably what's going to happen in Sri Lanka because they'll start with MTX anyway. But if there's secondary failure when a patient is not on MTX, add it and it can help. For primary failure, meaning you start anti-TNF and the child does not improve at all, then you probably have to switch what you're blocking to block either IL-6 or maybe a beta-sep. I honestly don't have so much experience with that, but when it is available, it has worked well. And here I think you have the options of adding leflunomide, sulfasalazine, maybe hydroxychloroquine, or the JAK inhibitors. Don't forget that for the RF positive or CCP positive kids, rituximab is a very viable option. So this is my strategy summary when I think about JIA, or when I think about any autoimmune disease really. FNF, T to T, WIT. This stands for fast and furious. For many pathophysiologic reasons, treating early and aggressively sets them up for success in the future. Treating to target. There's so much in the literature out there on this, I don't have time to talk about it. But just to bear in mind that as you're thinking about the patient, and even as you're talking to the parent, be very clear about what targets you're trying to achieve. And WIT means whatever it takes. And that also means using whatever you have in the situation you have. And when I shared this with a friend, I came up with this mnemonic. I don't know if some of you are familiar with it. I think it's in some cases a bad word. I do not mean that bad word at all. I just mean that when treating JIA, remember WTF. So bad arthritis in Sri Lanka despite MTS, what does it take? I think I'll leave this slide for discussion maybe at the second session, okay? Remember non-pharmacologic treatment. I feel that you're very good at this, especially those of you trained in rehab, so I won't be going into this. Just a few slides or one slide on prognosis of JIA. It's going to be poor if it is a RF positive poly-JIA. But what I mean in poor is that these patients are unlikely to be able to come off medicines. They'll most likely need it for life, but it still can be treated. The prognosis is also poor, or at least the ability to stop medicines is also less if they have ERA. And of course, the longer they take to treatment, meaning the longer they have untreated disease, the poorer the outcome as well. ANA is not a predictor of severity and outcome. In the West, it's a predictor of the risk of uveitis. The best outcomes are for oligo-JIA and for monophasic SJIA. The only thing I cannot tell you is who's going to be monophasic. I love this Facebook post from Dr. Suma Balan, and I think it just reminds us of how fun it is to do pediatric rheumatology. She wrote just about 1 week ago, what it means to be a pediatric rheumatologist. A young girl with deforming arthritis that cuts into her every activity can show so much improvement in just 2 weeks after starting therapy. The satisfaction of being able to make meaningful change in young children with chronic diseases. And I think that's another difference between pediatrics and adults. The ability for kids to heal and to bounce back is much higher. For many reasons, they're just greater. Pediatrician is being a bit biased here, but their pathophysiology allows that healing and their return of function much more than in adults. So do pediatric rheumatology. Last of all, talking to the family. Again, most of adult rheumatologists or rehab doctors here say, oh my goodness, not only do I have to talk to my patient and please I have to talk to the family. What do I say? Well, sometimes the first thing you need to remind these parents is that JIA is not like adult RA. To a parent, the first thing they think about when they think arthritis is the deforming arthritis that affects adults. Remind them, give them hope. It is true hope that this doesn't happen and does not need to happen in children. You have to remind them it's a chronic disease, but I always balance that with the hope that treatment is available. What about activity? What do you tell these patients? Again, this is a great thing about pediatrics. You don't have to limit a kid. They will limit themselves. And when they are ready and not in pain, they're going to start running and playing. In fact, in Singapore, a lot of the parents of JIA patients I treat tell me, oh, I've been limiting them, I'm telling them not to play. I tell the parents, as long as the kid is able, let them go. The child is probably the best person to know how much they should limit themselves. And because of all these, there is reason for hope that as we talk to our patients, I hope that we're able to communicate. All right, so many things we've covered. I suppose I could summarize them in these 3 take-home points. But to keep the learning going, I'll pass the time to Dr. Samara Farman's talk on JIA and its mimics. Thank you very much.
Thank you, Liz, for this wonderful talk. We can leave the Q&A session until after Sumara's talk because she's also going to join live. Dr. Smara has sent us a recording. We'll play the recording and then she will join in for the discussion. She is a professor and head of the Department of Rheumatology in National Hospital and Training, Research and Medical Center of Lahore. She is the, she's in the steering committee of Global Pediatric Musculoskeletal Task Force also, and she's the convener of APLA Pediatric Special Interest Group. So I think, Sumaira, your recording is working and we are going to play it. And please wait till the end so that we can participate to the Q&A session together with Liz.
Good morning, I am Bhuvan, Assalamu alaikum, and greetings to all of you in Sri Lanka from Pakistan. I'm from National College of Specialist Rheumatology and Application Sri Lanka College of Nutrition, and I am making this wonderful education activity possible. I am also wanting to express my sorrow and regret that I'm not there with you in person, but unfortunately because of a certain clash of dates, I was unable to make this trip, but I hope that hopefully in the next year or two, I will be coming myself. I'm going to speak to you about some limits of JIA, and I have tried to simplify this because this is an exhaustive list by keeping it simple and presenting it as 10 pages. These are my disclosures. Outline of my presentation is basically cases that are representative of different conditions like JIA and its inflammatory and non-inflammatory mimics, as well as non-arthritic musculoskeletal pain in children, which is often seen in our outpatient department. Please have gone over this with you, so just to reiterate that this is not a single disease, but a clinically heterogeneous group of chronic immune-mediated disorders, and we arrive at this conclusion after excluding other diseases associated with or mimicking arthritis. However, it remains the most common cause of chronic arthritis in children. My first case is of an 8-year-old girl with 2 years history of multiple swollen joints, morning stiffness and irritation from great fever. She was being treated as rheumatic fever with monkey intramuscular penicillin. When we saw her, she was miserable. Her clinical review labs were negative for systemic features, except that she had a great CSR. The examination revealed multiple tender swollen joints and a bilateral knee occlusion, as seen in the photograph. Her echo was done, it was normal. She responded to intraarticular glucocorticoid injection and methotrexate as our underlying diagnosis was that of JIA. Just to go over this, that this is a chronic history, 2 years history, and all negative features for systemic involvement. And her examination revealed polyarthritis. Which is all of these are, so all known causes were excluded, and this fulfills the criteria for juvenile arthritis. He said that this term encompasses all forms of arthritis that begin before the age of 16 years, persisting for more than 6 weeks, and are of unknown causes. However, it is not that simple. Arthritis may not be the prominent presenting feature, and I will go over a couple of cases with different presenting complaints than just arthritis. The second case is of a young boy with high cycling fever of 40-year pattern. He had a rash, he was ill during fever. Otherwise, he was well. He had a retinopathy and paracetamol, a high ESR. He was anemic with leukocytosis and thrombocytosis. So the differential at that point was, could this be an infection and could this be a malignancy? in view of his quotidian patterns, the fact that his rash came and went, that he was otherwise well, only ill during fever, otherwise he was eating and he was playful. Differential was made of systemic onset JIA, but we needed to rule out infections, and all his cultures came back negative. His biopsy, liver biopsy was done and showed reactive hyperplasia, and systemic onset JIA diagnosis was confirmed. A 9-year-old girl had a limp and was referred as it was not wing, and initially had been attributed to recurrent form of pain in school. She also had decreased visual acuity noted by the teacher and had an ophthalmology consult scheduled. She had no systemic complaints, but on examination the left knee was swollen with an increased limb length on that side. The lab work was normal except for a very low vitamin D. The X-ray showed a widened metastasis left pelvic contacts. At that time, the tentative diagnosis of critics had been made, with which she had been referred to us. As you can see, she had no systemic complaints. She had an increased leg length. The eye examination came back reported as having angiouveitis with cataract. And when you look at the X-rays, you can see that the metaphyses are widened. However, there is no cupping or splaying or fraying, and there is decreased joint space. This is oligoarticular. For the adult rheumatologists, and I think this has gone over this, but just to reiterate, that younger children may not complain of pain, they compensate well for loss of function, and any decreased range of motion has to be decided by the examining doctor. Some tools are limping, or parents might notice that there is morning sickness when they wake up. It is important to remember that children only have 10% with rheumatoid factor positive JIA, unlike adults. And in children, X-rays may be often normal initially. This may be greater thickness of the articular cartilage. And an MRI, particularly in early arthritis, may need contrast to show up primary inflammation. There is no single pathognomic clinical feature lab test to diagnose JIA, and like most things in medicine, the physical examination is imperative, and it usually leads to a diagnosis. And again, let me reiterate that this is all forms of chronic arthritis whose etiology cannot be identified. It is a diagnosis of exclusion, and we need expertise in trained expertise, whether an experienced pediatric rheumatologist or health professionals such as pediatric rheumatologists or pediatricians who are trained in pediatric rheumatology for early diagnosis. For the pediatricians, I just want to revise that arthritis is diagnosed in the presence of joint effusion or 2 or more of the bodies. So you need to show limited range of motion, with joint-like tenderness, and a painful range of motion. So the differentials of inflammatory arthritis can include underlying infection, whether part of the infection or as post-infection arthritis or reactive arthritis. They may be related to other inflammatory diseases such as arthritis, etc., to connective tissue diseases such as lupus, monogenic autoinflammatory diseases, and some miscellaneous conditions including immune deficiencies. So there are certain non-inflammatory diseases which may pose as arthritis when they may just be arthropathy, and these include bone and cartilage dysplasias like achondroplasia, etc., and metabolic storage diseases like mucopolysaccharidosis. So let's start with the first scenario, that is of a single joint. A single joint involvement can have various kinds of underlying disorders. It may be bleeding diathesis, would be due to trauma, which is quite common. You may have reactive arthritis, which is self-limiting, and you may have more serious conditions which must not be missed, like septic arthritis, osteomyelitis, or malignancies. And again, as a pediatrician or as a rheumatologist, you must refer orthopedic conditions to a pediatric orthopedic surgeon as soon as possible for early intervention. Once all of these things are not there, then even with a single joint involvement, you may sometimes see the beginning of juvenile idiopathic arthritis as in non-chronic. The first case is an 8-year-old girl with acute painful swelling of left knee for 2 weeks with painful lesions on the shins, and she has a history of sore throat 4 weeks ago. And the throat swab came back positive for beta-hemolytic streptococcus with a high ASOT and a high ESR. Her echo was normal, and she was treated with oral antibiotics. At the moment, she was afebrile, but her swelling was persisting. On examination, you can see her right knee is swollen, had painful range of motion, with some erythema, and she also had erythema nodosa. The repeat ESR and ASOT both had come down, and the aspirate showed an inflammatory cell predominance with a negative stain cell culture. So, just over this is the acute history only 2 weeks, not 6, and the history of sore throat was 2 weeks prior to the onset of the arthritis. She had erythema nodosa, and all of this resolved in 8 weeks. This was post-streptococcal reactive arthritis. It is important to remember that in any acute arthritis, infection has to be ruled out. And in the case of beta-hemolytic streptococcus, the resolution is usually within 10 weeks. Beta-hemolytic streptococcus usually resolves in 10 weeks. Okay, so this is the second case of a 9-year-old boy with gradually progressive swelling of right knee for 6 weeks and a leg. This had a normal systemic examination except the right knee was swollen and slightly warm, with a high ESR, and the X-ray showed right knee soft tissue swelling. An MRI was done which showed proliferative synovitis, mild effusion, and condylar bone marrow edema. An arthroscopic biopsy showed caseating granules. Important again, so this is a gradually progressive swelling for 6 weeks. Okay, the last one was just an acute swelling for 2 weeks. Secondly, there is proliferative synovitis and there is condylar bone marrow edema. So there is something more serious than just a reactive arthritis. And when you look at the biopsy showing caseating granules, this is actually tuberculous arthritis. Again and again, especially in developing countries in South Asia, where infection has to be ruled out in any acute arthritis, in any monoarthritis, even if it is subacute. This is a 6-year-old boy who was otherwise fit and well. He presented with lethargy and left knee pain and activity. He had an adaptive case. However, his knee examination was completely normal. When his examination was expanded to the rest of the joints, his left hip was tender with restricted abduction and internal rotation. The inflammatory markers were normal with a normal X-ray right knee. However, the left hip X-ray was diagnostic. As these patients basically had Burkitt's disease on the left side. And the important thing, this is an orthopedic condition to be referred, but it must not be missed. It must not be misdiagnosed as septic arthritis, reactive arthritis, tuberculous arthritis, or any of that. Because we had a patient who actually was opened up because there was a misdiagnosis that this would be septic arthritis. Another 12-year-old boy, again fit and well, with a negative review system for weight loss or fever, presented with groin pain and anemia. He had a BMI of 30, a right Trendelenburg was positive, with restriction of hip movements, particularly flexion and internal rotation. ESR was 20, and again the X-ray was diagnostic. Just remember that monoarticular arthritis in the hip is highly unusual in JIA. For isolated hip arthritis, we must consider Burkitt's disease, we must take capital pulmonary epiphysis, and these are again orthopedic conditions, and early referral to an orthopedic is extremely important to prevent long-term disability. Now we come to the second scenario, which is many swollen joints, plus the presence of a rash. This is a 6-year-old boy. He came with sudden onset migratory arthritis involving the knees, wrists, and ankles. A week later, he developed an urticaria rash. At that point, his CBC was normal, but he had a 9 ESR. He had no albumin missing transaminitis. His ALA was negative. His CT was negative, but rheumatoid factor was DK positive. His rash and arthritis resolved after 1 week, at which point he developed jaundice. And this is actually hepatitis B associated arthritis. The second case is a 5-year-old girl with difficulty breathing in preschool. 3-month history of a single swollen joint having attributed to trauma. Because of the difficulty breathing in school, she was referred to an ophthalmologist, and there was bilateral complicated anterior uveitis. Her ANA came back positive. A tentative diagnosis of JIA with chronic anterior uveitis was made. But later she developed a papular generalized non-erythematous non-anterior rash. At that point, a biopsy, skin biopsy was done, which revealed non-caseating granuloma. A 5-year-old girl with difficulty breathing in preschool. She had a 3-month history of a single swollen joint attributed to trauma. The ophthalmologic examination revealed bilateral complicated anterior uveitis, and her ANA came back positive on 140. So she was diagnosed as JIA with chronic anterior uveitis. However, she developed a papular generalized non-erythematous non-urticaria rash, and a biopsy came back as a non-caseating granuloma. She actually had suffered dactylitis and bilateral uveitis. This next case is a 10-year-old girl with a 6 months history of painful swollen joints. She was being treated at JIA with sulfasalazine. She then develops a rash and some hair loss, and the mother thinks it's a drug-induced. She stops her sulfasalazine. The symptoms persist, and en route to the city hospital, she develops seizures. On examination, she was admitted, and on examination, she had very high blood pressure. She had active urinary sediment. Her ANA and metastatic DNA were positive, and this actually is lupus nephritis. This case is of a 5-year-old boy with a 6-week history of fever, weight loss, and polyarthritis, and a generalized tendinopathy. This fever was persistent, not quotidian, and accompanied with weight loss. And he was very ill. He didn't have any period of being well. He was off his food. He was not playful at all. Unable to go to school, or even go to his bathroom or walk around the house without help. His labs showed a very high ESR, pancytopenia, and low titer rheumatoid factor positive. So, is it GI? When you look at the GI, the high factor test positive, is there any diagnostic test that you would like to do? Yes, bone marrow. And biopsy showed no proof of replacement of the bone marrow with leukemia. Please remember, GI is not associated with thrombocytopenia, with leukoplakia, with extreme pain, persistent fever, or persistent ill health. It's very, very important. So again, red flags, if you have chronic systemic features, always rule out malignancy, infection, and illness. What are the non-inflammatory units of GI? And I've taken out of this long list actually, I've just taken out these 4 conditions, and we will start with the first. Referred to us as the treatment for GI was not producing any improvement in the swelling of knees, although she had no pain or morning stiffness. On examination, she had deformities of hands and feet from capitectomy. She had salvitis in both her knees, and her lab work showed a normal CSR, but she did have a pericardial effusion. X-rays revealed soft tissue swelling, and an MRI of the knee was done. which revealed the dye was lining the bursa, and it showed almost as if the dye is going into the bone. And this was basically CACP syndrome, or compactodectomy arthropathy coxa pericarditis syndrome. It is important to differentiate this from JIA. Pardon, I meant that the contrast is going into the bursa, which is lining the joint, and it looks as if the contrast is going into the bone. This next case is a young boy on treatment for JIA. No improvement. He had contractions of his hands, he had a bottling gait, he had a normal CBC ESR, and as you can see the x-rays which are shown here. You can see that there is widening of the interphalangeal joint area, as well as contractures. And as you can see that the spine x-ray shows anterior dipping of the vertebrae, and as well as you can see that the angle of the femur is showing the coxa vara. He wasn't described with fractures in his hands, but the joint line was essentially bone tender. He had a working gait, and x-rays of the pelvis showed irregular enlarged indices of the head of the femur and narrowing of the joint space with early changes of osteoarthritis at the hip joints. When we look at the lateral and dorsal lumbar spine, you can see fatty spondyly and anterior of the vertebrate bodies. And when you look at the x-ray of both hands, it shows a large phalangeal epiphysis and metaphysis with early osteoarthritic changes in the vertebrate joints. There's also very mild periarticular osteopenia. This is progressive pseudomotor arthritis, which are also known as spondyloarthritis states and other progressive arthritis. This is a 13-year-old boy with difficulty in walking, yet painful feet and progressive deformity of the ankles. The ankles on examination were deformed, as you can see, with restricted range of motion, and x-rays can reveal resorption of tarsal bones. This is inherited multicentric osteolysis, and this may present alone or present with other syndromes which may include nodulosis and facial lesions as well. There is a genetic component to this, and that variant may be different in certain syndromes. This child was actually referred to non-responsiveness to vitamin D, as she was initially treated for rickets, and then non-responsive to methotrexate, being treated as JIA, and then sent as a second opinion for achondroplasia. However, the clinical features and x-rays are diagnosed. In examination, she did not have any features of JIA, and when her x-rays were taken, they are quite diagnostic. As you can see, there is thoracolumbar scoliosis, there is anterior and inferior vertebral body aching, and O-shaped ribs. And as you can see, the changes in the limbs and the hands are collectively known as dysostosis multiplex. So this was a case of mucopolysaccharidosis. In her case, it was morpheus, which is not that often, mistaken for JIA, but in this case, she was. Let's talk about non-musculoskeletal pain. During childhood, this is quite common, and several population surveys have shown that up to 16% of school-age children may report in pain. Please remember that non-rheumatic causes of musculoskeletal pain. So pain and arthritis are different. These are much more common than rheumatic causes. And joint pain, in case the musculoskeletal pain is due to joint pain, the joint pain has multiple etiologies, not always inflammatory, as I've just spoken previously. When you look at musculoskeletal pain syndromes, there are four that are generally mentioned, which are growing pains, which will happen with fibromyalgia, and reflex sympathetic dystrophy. I'm only going to talk about the top three. A 12-year-old girl with a 3-year history of diffuse muscle pain, weakness, and significant fatigue that limited her ability to work. Her sleep was disturbed, but the examination was normal, and she had 10 out of 18 tender points positive in all 4 quadrants of quadrant axis skeleton. Her lab was positive for ENA and titer, the rest were normal. This is juvenile fibromyalgia. And yes, for adult rheumatologist, fibromyalgia does exist in children as well. And these, again, ANA positive in up to 32% of children without identifiable reason or following an infection. So just an ANA positive does not mean lupus. Another 10-year-old girl with multiple joint pains was referred. Her joint swelling was excluded on examination, and she fulfilled the guidance criteria for high-sensitivity. Her diagnosis of renal joint hypermobility is confirmed if 3 of the 5 signs are present, which are given over here, which is habit extension at the MCP joint, habit extension of the thumb, increased angle at the elbow, and increased extension at the knees, as well as when you move forward, there is increased flexion at the spine, and the child is able to place both hands flat on the floor. Just a mention of growing pains, because any child that comes with pain in their legs, that is the differential sometimes. It is important to remember that growing pains will occur in a child who is otherwise well, and usually between 4 to 8 years. And this pain can alternate between legs. It is located between joints, not over the joint. Usually occur at night, but will subside within 10-20 minutes. If you rub the leg, if you give an analgesic, and otherwise the child has been late, they are walking normally, there are no objective clinical signs. And it is at this point we always want to rule out serious causes. So any serious cause of leg pain may be accompanied with fever, weight loss, it occurs at any age. It will occur in one particular way regularly. There may be pain in the joint. It can occur at any time of the day or the night. It is persistent, prolonged or chronic. It may be accompanied with a limp or refusal to walk, or they may be redness, swelling or reduced range of motion. I just want to just share that part of the reason why we are having this session is that there are not enough pediatric rheumatologists globally, and definitely not in the Asia-Pacific region. And this 2021 Paediatric Rheumatology survey showed that there is a lack of conventionally trained pediatric rheumatologists. So that health professionals who have special interests, whether they are adult rheumatologists or the pediatricians or family physicians, they were the ones who are actually taking care of children. They see them before they get to pediatric rheumatologists. And so in Pakistan, we are all rheumatologists working as pediatric rheumatologists as well. And even in countries like, which is relatively understandable and better in Sri Lanka as well. But even in India, where they have a very good proportion of fully trained pediatric rheumatologists, majority are still those who are health professionals with special interest. And surprisingly, actually even in Australia and New Zealand, which are first world countries, there is a large proportion of health professionals who are non-pediatric rheumatologists, conventionally trained, who are seeing these children. And care is generally delivered by rheumatologists, pediatricians, and general physicians, etc. And thus we have a lack of critical mass of specialist pediatric rheumatologists, which is the main barrier to pediatric rheumatology training. And we need to empower more pediatric rheumatologists and professionals, increase the workforce capacity through different out-of-box learning, including remote learning or activities like today. I would like to give a shout out to my wonderful pediatric rheumatology special interest group team, after which Gayatri has arranged this wonderful activity, and Liz is participating as a Suma and Suleiman, and we are hoping to work together and increase pediatric rheumatology presence within the Asia Pacific so as to better train our health professionals and youngsters who are dealing with children with rheumatic diseases. So we have had the APLAR Paediatric Rheumatology SIG webinar series, and they are being successfully conducted, and I think they have provided a good resource of learning for our postgraduate trainees as well as our health professionals who are taking care of these children. Many members of our special interest group are also members of the MSK Paediatric Global Task Force, and we hope that this collaboration will work towards improving care to our children with rheumatic diseases. As I mentioned, I'm a rheumatologist primarily. With the mentors in pediatric rheumatology, I want to acknowledge and also acknowledge the institutions that have helped in training, and both in certification as well as in clinical expertise. I'm also very proud to be part of the Arthritis Foundation as a co-founder and as the co-chair. And this is an entity in Pakistan where we have actually up-to-date most often, or we have government hospitals. But because many understand that there is not enough expertise and there are not enough resources in Pakistan as well. So this foundation basically sponsors and funds scholarships in rheumatology training, as well as clinics, free clinics, and joint replacements, and funding treatment for medicines including biologics. And we hope that this is something that is done at a non-governmental level, and it is a good kind of what is the word? It's model. It's actually a good model for other countries to follow as well. And the whole concept being that, we have to help ourselves, really help ourselves. Of course, all of us, children are our world, those of us who have children and grandchildren, like myself. And I just want to acknowledge my wonderful team in Lahore, and also our partners who work with us, like the NIH that is working with genetic studies with us. I want to thank you for your attention, and I am open to any questions. Thank you very much.
Sumaira, we can see you. Yeah, thank you for your most wonderful elaboration of, JIA mimics. Now the forum is open to discussion. Liz, it might be good if you can come up again. This was meant to be an interactive session, and I think as a person involved in pediatric rheumatology, I think I had to learn such a lot listening to these veteran speakers. I can see where I am, that was a very illustrious 2 lectures that we listened. Please make use of this. Please ask questions to clear your doubts where I have many questions to ask. And please come here. So what I have to say is, sometimes I was in doubt. I was all alone, like feeling alone, because I did not know sometimes whether I did the correct thing, because I left my comfort zone to come to pediatric rheumatology. I was so scared to come in. It was a new, huge learning curve, and I must admit I'm still there in the learning curve. It's so helpful for me, the time that I spent with Liz yesterday and the few APLA SIGs that I participated. So it is an opportunity for the audience to interact and learn. We have ample time to discuss. Please pause your questions. Sumara is online and looking good. And Liz is here, and there are two expert speakers on the audience as well. Please ask questions freely. I know you take time to make up your mind to ask questions, so I have a few of my own. Okay, right. So, I have a question to Liz. When we are using, it's kind of a practical question. These things come haphazardly, I know. When we give adalimumab, that comes in a fixed dose vial. I don't know how you take it out, how to dose that. I don't know whether the audience has that experience. I know that there are certain centers in Kandy and all, we use adalimumab, but we get this preloaded 40 milligram syringe. I would like to know how you do it, Liz, practically.
Sure. First of all, I want to say I'm quite a nerd. So instead of going to a country to see the tourist attraction, I asked Madam yesterday if I could go and see the hospital, because these things make me more excited than tourist attractions. And actually what I want to say is that I'm very impressed by the care that you all give to your patients here. And I'm saying that as someone who, in my nerdy way, have gone to a lot of countries in Southeast Asia just to see what's being done. So I'm very inspired by how much you all can do and what you keep trying to do. The question about adalimumab, if you only have 40 milligrams, now the guidelines say more than 30 kilos, the dose is 40 milligrams. Less than 30 kilos, the dose is 20 milligrams. But you may not have it, and in reality, in Singapore, the 20 and 40 milligram cost the same. So what do we do practically? Well, honestly, I just give them the whole 40 milligrams. Let me show you why I have confidence to do this. Meaning, you can confidently give a child who may be under 30 milligrams, 30 kilos, the 40 milligram syringe. Number one, in IBD, when they start adalimumab, they load the patient with anything from 80 to 160 milligrams. The poor IBD patients, at the initiation of IBD treatment with adalimumab, they get 4 injections, and they're fine. So that is one way where you can say, hey, giving a little higher than recommended is probably okay. And then the second reason why I have confidence to give children maybe a little bit more than the guidelines is because in the very severe patients, for me it would be the cases with CRMO or CNO, I have had to give a 3-year-old kid as high as 40 milligrams every week to get efficacy. So that is totally anecdotal, but from that I have the confidence to say, you can be practical. I don't split the syringe. The adalimumab comes as a pen, and it's impossible to split the dose anyway.
May I add to that?
Sure.
Thank you, Liz. In Pakistan, also what we do is, because sometimes the cost is a factor. So if you calculate the dose, and weekly dose and multiply by 4, so the monthly dose that they divide. So in case the dose is coming, say the child should be getting 20 grams a week, the 40 is then given twice a month. And I think this had to give a little more and never had any problem.
Thank you so much. That gives me confidence. Sometimes I do that too. Sometimes we do little tricks to separate out the doses. We put it, we stop it, halfway. Sometimes we try to do that because I'm scared. Now it gives me more confidence. So, cost is a factor as well. And my next question was to be, I also use these doses that are not in the literature. Adalimumab is usually 2 weekly, infliximab is 0 to 6 weeks, and then 2 monthly. But I sometimes have to give, monthly infliximab, 2 weekly infliximab. How is that? Is that all right? So I sometimes have to do it. Yeah.
Yeah, I think it's all right. I was also wondering whether. Okay, let me answer that question more directly. Yes, I think it's all right. For the patients with very bad JIA, very bad uveitis, or very bad other autoimmune conditions, in my slide I wrote some people use up to 10 milligrams per week, 10 milligrams per dose every 2 weeks. Yeah. Happy to hear Sumaira or even Suleiman or Suma's thoughts on that.
Yes, I'll say that I agree. The only thing with us in Pakistan is, to worry about the doses and anti-TNF. So I suppose that is in Sri Lanka as well. You must screen all patients who being given biologics for 2 doses. We're all EGD vaccinated. So, the monitoring doesn't work. You have to actually do the monitor on hold, and that is positive, that may signify late TB, and so we refer these kids to the infectious disease, and they review them, and sometimes they will, as has mentioned, put them on prophylactic ATG for like a month and then give them medication. So as long as there's no infection and you screen them for hepatitis B, C, and ensure that there's tuberculosis, it's okay to monitor them clinically and give the doses.
Dr. Suma might have similar experience. There's a mic.
No, I agree with all the deliberations. I think we try to match the dose because we have availability of 20 and 40. 20, we don't have the originator adalimumab at all, but we have a huge number of biosimilars, and so it's very easy to get. It's not that expensive. Once there are many companies in the market, costs come down. That's what we've always seen. So we give. And our 20 milligram is cheaper than the 40, not 50%, but it is cheaper. So for the patients where 20 is adequate, we all the little toddlers with uveitis where we're using 20 is often adequate for that age group. And like you said, if necessary, you can go up to it, doesn't matter.
We agreed with what Liz and Sumaira mentioned, but we have the privilege to have both doses, 20 and 40 milligram of adalimumab. Probably I would suggest something, if you have only 40 milligram and you don't want to give higher dose to, the concern here is the side effect. So you don't want to give higher dose because as per the pharmaceutical company, you shouldn't use higher dose. Now, what is the difference between 30 kg and 29 kg is nothing. And I agree with Liz, the GI colleagues, they give higher dose. And sometimes we use weekly adalimumab for uveitis. Now, if you have 40 milligram and you are concerned about the cost, all of us concerned about the cost, we used to do something with canakinumab because very expensive medication. And unfortunately, the vial 150 milligram, we couldn't give it for small kid. So what we used to do, we split the dose by the pharmacist, not by us. So we asked the pharmacist to split the dose between 2 patients. So we save the time, we save the money for the patient, and we give the proper dose. Now, if you have the facility to bring the patient every 2 weeks to split the dose between 2 kids, 20, it will be more appropriate. But if you don't, probably 40 milligram, as Liz mentioned. Now, for the infliximab, we don't like to give lower dose, although we don't use infliximab that much. We go directly to the higher dose, because the higher dose, the less side effect and less antibody production.
Yes, I agree with Suleiman. We've done that, called 2 patients together and had split the dose from the pharmacist. We've done that. Yeah.
We do the same with, tocilizumab and infliximab. We get down everybody in one day and split the doses. Yeah.
We actually found that experience of splitting with anakinra, because our children on, who have the autoinflammatory disorders on daily anakinra, we found quite happily that we are able to split the dose to a daily dose and saves them a lot of money, and it works. Anyway.
Any questions from the audience? I have so many questions. I think I will, yeah.
From the expert panel, 2 questions I have, so 2 different areas, so I'll ask them together. I am being a more predominantly adult rheumatologist, but whoever the juvenile patients I have are mainly oligoarticular type. So first question I always bothers me is, when do I stop treatment for them? Number 2, Liz mentioned about giving higher dose of methotrexate for children without for adults probably the recommendation is rheumatoid maximum 20 per week and psoriatic probably 25 a week. Of course, there's no weight related dose. So do you think that we can, even children, even they're smaller, we can go up to that level? That's the second question. So 2 questions.
Second question, yes. I'll let Liz answer.
The second question is much easier. You asked whether we can go up to 20, 25 in kids. Yes. And I think in Boston, they would go up to 30 milligrams. So their maximum in a child, based on their weight, would be 30 milligrams every week. The only problem with going to 20, 25, and 30 is that the oral bioavailability becomes less. So in terms of safety, 20, 25 per week in a child, generally no problem. But if I'm going to those doses, I would be thinking about giving it subcutaneous, more for efficacy rather than safety. The second question, I think I'm really going to throw it out to all the experts, because it is a question of when can we stop treatment. That is really a very tough question. Generally, polyarticular, RF positive, probably never. ERA, I try. And practically speaking, how I try it is, if they're on anti-TNF, I will start reducing every 2 weekly injections to every 3 weekly. For how long? Again, I honestly say this is anecdotal. I'll try it for 6 months. If they're still good on 3 weekly injections of adalimumab, I will do it for months, for 6 months. Why it's so difficult is because there's so many subtypes. It's so hard to do studies. And our fear, no matter how well the child is doing, is a flare and the difficulty of recapture, right? What you read in the studies is this idea of recapture, because the kids theoretically and practically can flare, not just in their previous joints, but in more joints. And we think and we hope that giving them the same medicines that used to control them would be easy, but sometimes that doesn't work. So how do I summarize this? I think the longer they've been in remission, the more likely you're going to be able to reduce. Do you reduce after 6 months, 1 year of complete remission? Anybody's guess. Do you reduce by reducing the dose of MTX or by giving it every 2 weeks? I think practically the pharmacodynamics is that you reduce the dose rather than increase the interval. But yeah, that is a really tough question. I'm going to let Suman, Sulaiman, and Sumaira speak to that, okay?
I think pretty much Liz has put it accurately. You just have to feel your way. One should not rush it. Parents will push you. I know it in Pakistan. So the merits of having internet access, they read up all the side effects of medications, and they keep pushing you and pushing you. So you have to keep pushing back and tell them that it is worse to control disease than any potential side effect of the DMR, that you are monitoring the medicines, and that they should sort of ensure not to rush putting their child in danger of having a relapse. And I just want to add a little more about the oligoarticular stopping DMR. So sometimes when the arthritis is settled, uveitis is flared up. So it is recommended that once you stop, if you taper and stop, you must still keep monitoring the arthritis is controlled, you must keep monitoring the eyes for uveitis. So the chronic uveitis is silent, and in young age they do not know that it is affecting nutrition. So you're doing asymptomatic to the observer and asymptomatic young child. Over to Suman and Suman.
Yeah, I think I agree completely. There's no evidence-based guideline on when to stop, how to stop, and I guess people have their own style of doing it. For me, it would have to be that there should be no systemic steroids anywhere in the patient. The patient should be completely in remission. I should not have needed to have given a joint injection for quite a while. If the child also has uveitis, then there should be no need for systemic or topical steroids. We should have been off topical steroids for a good at least 6 months to a year. In fact, I would say, before I would think of reducing steroids. If it's a case of uveitis and they're on biologics plus methotrexate, I would probably think of taking off the biologics first, because it's more expensive, even though Western experience dictates the contrary. So basically, if once you do that, and we do that by spacing out the injections in case of the biologics, but with methotrexate, I do it by reducing the dose slowly, very, very slowly. I warn the patients that there's a chance that as we reduce, we go down to half the dose, they might actually flare. And we can't help that, we still have to try it. If they flare, we have to restart. And that's where we do it. I guess about 50 to 60% of the time you're successful. Then you have flares, and then you try again, and then you try to reduce again when it's time.
Probably I have a bit different opinion from the dose of methotrexate. I never exceed 15 milligram, and there is evidence that more than 15 milligram will not be different from higher dose in pediatrics. So basically we don't exceed 15 milligram. Now if the patient on oral, we can switch him to subcut rather than increasing the dose. And now for that, weaning the medication and stop it, I agree with Soma. If the patient on combined treatment, personally, we prefer to wean the biologic and keep the MTX at the end. And we are not in hurry to wean and stop medication. At least, we need it more than a year for methotrexate, providing there is no side effect or contraindication.
I completely agree with. Can I just add? So Sulaiman is absolutely right with your recommendations, but I know that in life, in the clinic, we've had experience that kids do respond to high dose when you cannot come to biologics. So we do give higher doses of methotrexate, especially where we are not able to switch to biologics. We do not have data, but this is something that's basically like a visual type of situation, and each situation is slightly different. So that's one thing, and the other is very valid and completely agreed with the opinion Suleiman and Moses as well. I think the thing to remember is that every patient is different and every situation is different. You just have to try your best and do it safely. So as long as you monitor what you're doing, then hopefully you'll be okay.
And what is the experience in combination of synthetic DMARDs? Because most of our patients not tolerate higher doses of MTX. Then combination of synthetic DMARDs like MTX with leflunomide or the sulfasalazine in JIA patients.
So the question is how to use the combination?
Yeah. What is the experience? How efficacy the use of combination?
Yeah. So the last time I've used a combination, and for us, when they think triple therapy, they're thinking hydroxychloroquine, sulfasalazine, and methotrexate. In peds, when I think of triple therapy, because hydroxychloroquine doesn't seem to work so much, especially for the non-RF positive, then I'm thinking of methotrexate, sulfasalazine, and leflunomide. The last time I've had to use this was more than 10, 15 years ago because we have biologics. So I can only speak to the experience from more than 10 years ago. I think it can work. And when there are no biologics, we just are trying to push everything. In terms of safety, these three, I've not had problems in terms of safety, but in terms of efficacy, it's hard to tell. Again, I know the ACR guidelines will always say, no, triple therapy is not favored, but in many of the countries where we practice, and for me it's because patients fly into Singapore and they don't have biologics, then I would say it's definitely worth a try. It's not entirely useless.
Yeah, may I respond to that?
Yeah, sure.
Because we do still have to use more than one conventional DMR. And we actually published an abstract in APLA like 2 years ago on where we used leflunomide up to 1 milligram per kg, which is not published, and looked at the safety and tolerability, and the case is fine. And so generally if you combine it with methotrexate, one will not go to 1 milligram per kg, one will stay lower, not more than 5 milligrams, but as I look at it, dialysis tolerant methotrexate, non-responsive methotrexate, unable to take sulfasalazine or unable to treat sulfasalazine in combination with leflunomide. And we just have to go with leflunomide, we have to do like that. And probably 3-4 years later, we've not had any problem. And I think probably because there's no underlying liver so then it does when you combine methotrexate with leflunomide, there's a warning that this would be toxic. But probably because we have had a liver, we've not had any problem. So yes, we have combined both, and we have combined sulfasalazine as well. But you have to be very careful with monitoring the counts, the liver function, the kidney function, and make sure that the children's parents understand these illnesses, they have to stop these DMRs. And you cannot just sit there with the unknown, keep having medications and no lab work. So you have to actually counsel them, and some reason you cannot come, please ensure that they're doing your lab work and then post it to us. Because or show your local doctor because if there's any problem there, you need to stop. So you need to counsel them, you can't send them off without telling them that it would be dangerous. But we have had excellent safety and tolerability and efficacy as well. Because a lot of kids can't, even if you are trying to sponsor and fund them to biologics are expensive.
I think the biggest combination, biggest number of meds in combination yesterday in my clinic because in my desperation I use a lot of them together and I don't know which one to stop because I try one by one to withdraw. I add one by one and when I try to withdraw one, they get a flare. I think she got scared by seeing my giving D1s together, but I have no option because I have tocilizumab now and next month I don't get it and so it's difficult. I do that all the time.
We do the same, Gayatri.
Yeah.
Yeah, we do the same. You just have to make sure you're safe.
Yeah.
You counsel them and you are meticulous about the lab work and monitoring. Cover them for infections and everything. Yeah.
Okay. Thank you. I think we no more questions from the audience. We had the most wonderful discussion. I think it's a very interactive and very live discussion. Thank you so much, Sumara, for joining after a lot of things happened to you,
Yes, a lot of things happened. I'm sorry the recording was broken up many times, lots of logistic issues, but I'm missing not being there. Lovely to see Liz and Jayari and Suleiman and Uma. I'm so jealous I'm not there. So you have to, you can't have all the fun alone and keep some for me when I come.
Okay, thank you so much. Yeah, and Liz too.
I think fantastic presentation, Liz. Really enjoyed it.
Yeah. Yeah. I think we have to break up for tea now. It's time for tea. Tea will be served out there at the same level this morning. And please come back to the next session at 11:30. Thank you so much. Yeah.